The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to the Academy's presentation and with your colleagues to Service and Revenue Opportunities for Housecall Practices. We're going to focus on the Professional Fee Schedule Final Rule for 2013. Our agenda this afternoon is to touch on the Patient Protection Act, highlighting some issues relating to the traditional Medicare fee-for-service program, Medicare managed care, Medicaid demonstration programs, then focusing on the rule for 2013 with particular focus on revenue opportunities for your practices. We will save the changes to quality reporting programs, the electronic incentive programs, and implementation of the value-based payment modifier for a standalone webinar in the interest of time. There's about 30 slides we'll be going through this afternoon, and we want to spend some time with those. We will be posting this to the Academy site, so it'll be there for your reference, and we'll also post the references to the regulatory materials cited. So what we know so far from the election this year and the Supreme Court case this summer is that the demonstration programs, ACOs, IAH, continue. This, as you were probably experiencing, as we're hearing from you, is providing support for public and private market development. Related to that, the Academy presented a September 2012 webinar on ACOs and house calls, and that's posted on the Academy site. Medicare managed care, as we know, 1 of 4 beneficiaries across the country is now in a Medicare Advantage program, many of whom you have relationships with for the care and of those beneficiaries and your practices. We expect that market to have continued growth, and opportunities are presenting themselves to your practices for the high-cost patients, admission avoidance, transition care management, patient assessments. One thing we want to note brought about by the Act of a couple years ago is that the increase in the requirement for medical loss ratio requirements on health plans may present opportunities for additional services and additional opportunities for you to interact with health plans regarding your house call services. And the resources are posted on the Academy site from prior annual meetings in relation to discussions and negotiations with Medicare Advantage programs. Medicaid, the Act provides for an expansion in beneficiaries. There may be some state-to-state variation as to how states approach that increase in beneficiaries based on income level. One thing that we do know, and we'll spend some time on this afternoon, is a payment rate increase for Medicaid beneficiaries, and that was in a November 6th final rule that we'll discuss in some detail. And then the traditional Medicare fee-for-service program. What we do not know is what will occur over the next couple months regarding sequestration, the federal budget, and the disposition of the sustainable growth rate. As you'll see in published materials, the conversion factor reflects the 26.5% reduction. That's the cumulative reduction from the impact of the sustainable growth rate over time. As we know that Congress has intervened annually to mitigate that reduction, and the Academy is advocating and has signed on letters with organized medicine to see that that occurs again this year, and would hope for your support out there in the communities with your representatives along those lines as well. What we do know in the final rule is that there are no significant RVU changes to house call codes, and there are new services, coverage and payment, and that's what we want to move on to discuss. There is an emphasis and an appreciation, growing appreciation in CMS regarding primary care services and chronic care management. That's evidenced by their work on the advanced primary care medical home. CMS is working on concepts and models to support that, and the Academy is working on your behalf in that regard. 5 codes were accepted by CMS this rulemaking process for effect in 2013. 2 of those will be covered and paid. Those are transitional care management codes we'll be discussing shortly. 3 others relate to complex chronic care coordination. Those new CPT codes were accepted, and you'll see those in your electronic and manuals effective next year. However, there is no Medicare coverage at this time for those codes. Moving on to those codes, you have helped to value these codes through your survey response, and the Academy is working with Organized Primary Care to have these included in the Medicare fee schedule rulemaking process for 2014, and that rulemaking process would be what we see occur in 2013. The description of the complex chronic care coordination codes is provided here for your benefit. This is the language that CMS accepted from the AMA RUC process, and you'll see that it involves the no face-to-face types of services with complex patients. It does not require an admission of the patient into a facility. Again, this information is provided for informational purposes at this time. These services you'll see coded next year. There's no mandate for reporting. However, they are not going to be covered and paid by the Medicare program. Moving on to the codes that will be paid. New transitional care management codes, 99495 and 99496, will be used to report transitional care management services. These relate to patients with moderate or high complexity, requiring moderate or high complexity medical decision making during their transitions in care from inpatient hospital settings, including acute hospitals, rehab hospitals, long-term care hospitals, partial hospitalization status, SNFs, etc., to the patient's community setting, the home, domiciliary care, rest home, assisted living. The difference in the 2 codes, the 99495 and the 99496, is that the 99495 relates to moderate decision making, and the 99496, your involvement with the patient requires high complexity medical decision making. Another key distinction between the 2 codes is that in the moderate setting, you need to see the patient within 14 days of discharge, and with the 99496, that is a 7-day requirement to see the patient within 7 calendar days of discharge. So this slide is a high-level overview of the requirements in the 2 codes. The difference between the moderate decision-making and the extensive or high-complexity decision-making, that relates to the number of management options, the amount, complexity of data, and the risk of complications. So again, you see that on the 99495, transitional care management, you need communication with the patient within 2 business days of discharge, medical decision-making of at least moderate complexity, and then these 2 codes do include a face-to-face visit, the moderate level one within 14 calendar days, and then the high complexity 7 calendar days. Realize there's a lot of information on this slide. Again, these will be posted for your reference on the Academy site. Moving through the left-hand, down the left-hand column to highlight some of the features of the codes. Again, the communication with the patient or caregiver, that's within 2 business days. Saturdays and Sundays are not counted in the 2 business days. There's no assumption on CMS's part that the weekends are part of, and they didn't want to impose the requirement that there is a 7-day operation for practices. There's an expectation that you do contact the patient within 2 days. However, there can be 2 attempts made to contact the patient, and you should be documenting those if they're not successful to reach the patient. The medical decision-making, again, the columns are similar, except that you'll see for the medical decision-making and the time frame to have the face-to-face with the patient. Medical decision-making, again, moderate complexity with the 99495, high complexity with the 99496. A face-to-face encounter with the patient is included and is not separately payable as part of these individual codes. Again, 14 calendar days with the 1 code, 7 calendar days with the higher level code. The services that are expected to be documented by the physician or other qualified provider, and these services can be rendered by nurse practitioners, physician assistants as well, are listed, and as well as the non-face-to-face services by clinical staff under the direction of the physician or the nurse practitioner, physician assistant, etc. You'll notice that these services are CPO-like, and we'll get into the discussion of that a little bit more as well. Obtaining and reviewing discharge information, reviewing the need for follow-up when pending diagnostic tests and treatments, interaction with other professionals who reassume care of patient system-specific problems, education of the patient, family, guardian, or caregiver, establishment or reestablishment of referral and arranging for needed community resources, assistance in scheduling required follow-up with community providers and services. The non-face-to-face services by clinical staff would include that communication we discussed, communication with home health agencies and other community services, patient, family, caregiver education to support self-management, independent living, and activities of daily living, assessment and support for treatment, regimen adherence, and medication management. There is an expectation of medication reconciliation during these encounters and for these services. Identification of available community and health resources, facilitating access to care and services needed by the patient and family. Okay. Moving on to the next page, which is a higher level overview of the requirements for the service and claim requirements. I want you to notice that these services, the transition care management services, are live once for the patient for the first month or 30 days, inclusive of the day of discharge. So they're sort of 30-day codes. The claim submission and adjudication, that'll occur after 30 days post-discharge because they want to see that the services, of course, were rendered within that time frame. One change from the proposed rule to the final rule is that discharge day management services can also be provided to the patient by the same practice that renders the transition care management codes. That was not provided in the proposed rule, but it is in the final rule that discharge day management and the transition care management codes can both be rendered and submitted. However, it cannot be by the same provider seeing the patient on the same day. There are claim exclusions for this service, and those that exist, again, for the first month only, and that is for care plan oversight and other similar coordination types of and non-face-to-face CPT codes, and those services, again, will be posted. But I want to bring that to your attention that, and there is no requirement that these patients be patients that involve home health agency services. In fact, these are available to all patients, meeting those complexity requirements. However, do want to point out this claim exclusion for the first 30 days to you. On the other hand, additional medical necessary evaluation and management services can be rendered to the patient within the first 30 days, and claims submitted. The total RVUs are provided on this slide for you, and then the payment level for these two codes. So that we see for the one level it's $164. If at the 2012 conversion factor of about $34, and then the higher level code at $231, again at this year's conversion factor. There will be the beneficiary copayment. That's one reason they included the visit in with this service. They wanted that, they being CMS, wanted to provide that clarification and expectation by the patient for the copayment involvement. So there is the 20% copayment element in place. Also included the Medicare expected utilization of claims for each of these services. And then regarding questions whether these services would be part of the primary care incentive program, that program includes statutorily listed CPT codes, and this being these codes not being part of that listing, these would not be included in the PCIP program. What the next slide is to provide you a framework to consider the codes and integration of the codes into your practice. What I've done here is to reflect the 99495, and then in the next slide, the next level code against the established level codes, moving from left to right. So we see the $164 for the 99495, and then on the established level codes detailed 99349, comprehensive 99350. We have the payment levels of Medicare listed. Then I've dropped down to an expanded level established code, but adding the CPO just to kind of give you a flavor of how that interacts and what that looks like, and then adding in the detailed level code back with the CPO, the expanded with CPO, and then with prolonged services. And what we see at the bottom is that there's the payment of $164 just for the transition care management code. Again, there is not a mandate to use this code or an exclusion of not to use an established code where that's appropriate during the 30 days, as your current practice exists now, or a new patient visit code when you're seeing the patient or within your practice for the first time in the 3 years or the same specialty, et cetera, in that first 30 days. So those opportunities still present themselves. Again, just want to reflect the payment levels and how other services interact. The 164 for the transition care management code, that would be more than the detailed level code with an established patient. It would be less than a comprehensive level code. Then it would also be less than any of the established codes with the CPO involvement, and with that being a home health agency patient. The next slide, we do the same thing, but with the code that's high complexity, paid at $231, and again, comparing it with established codes. And again, we see that at the $231, it is more than the established level codes until we move over to the expanded one with CPO and with prolonged services. If we were to compare this with a new patient, there was an expectation on the part of CMS in the proposed rule that these patients would be known to the practice, and there was an expectation that you would have seen the patient 30 days prior to using this code. That requirement was dropped in the final rule, so this patient can be established in your practice or new to you, and the opportunity still exists to use these two transition care management codes. With the new patient codes being paid at a higher level, the two highest level of new patient codes with CPO would take those payments above the 99496 for a patient with high complexity. Again, that's where those services would be appropriate. Considerations for the transition care management services. Your practice status. There's no restriction to site of service or specialty. These are not primary care specialty only codes. The home is mentioned in the final rule. That is something that the Academy actually sent into CMS. We wanted to make sure that they were aware of our settings for these codes, and that is specifically noted in the final rule. Practice status, structure, composition, life cycle of your practice. What markets, referral sources? Do you have any office-based practice? These services are available also to office-based practices. New practice, this is another service for you to market. Patient acquisition. Do want to bring to your attention that CMS will only recognize and pay one of these codes per patient. So this is a matter of patient acquisition. CMS has an expectation that the patient will, in a sense, identify or have their services attributable to a provider rendering these transition care management services. So in terms of patient acquisition and using these codes, you want to make sure that you're knowledgeable about the patient and documenting rendering these services and have that relationship established with the patient that you are providing these services on their behalf. Hospital market, are you moving towards hospital markets in terms of readmission avoidance, hospitalist relationships, discharge planning, in relationship with ER providers? Hospital system-based practices. Again, the discharge day management can be provided by the same practice, but it cannot be by the same provider on the same day. So for hospital and system-based practices that do have a office-based component or doing rounds and teaching as well, there's the opportunity both to provide the discharge day management and also then to see the patient in the community. Health plan ACO relationships. Again, the admission-readmission avoidance issue. These codes and the payment now establish a market price around coded services to package. Again, want to mention the medical loss ratio issue, where some health plans will be needing validated coded services to pay for it to meet the requirement of percentage of medical loss ratio. So we want to encourage the presentation of these services along with your other services about the value of house calls and the chronic care management codes, now that they've at least have RVUs attached in your negotiations with health plans. Considerations with home health agencies. Again, what percentage of your practice and what role does CPO play? Recognize that this is a different service. There's no home health agency requirement in place. However, as you saw in the discrete elements, there is an identification of need or potential need for home health agency and coordination services. So that provides a value added to your practice. Same regarding nursing homes, SNFs, and assisted living facilities. Practice composition. What is the number and type of your providers? What is the ratio of established patients versus new patients? Do you have different specialties? Again, perhaps someone would see the patient on a transition care management basis. You then have that information available, and then if the provider who sees the patient is of a different specialty, you may meet the requirements for that patient to be still a new patient to the practice. Practice preparation. Now that we have some time before the beginning of next year, would encourage you to work on the documentation templates and your electronic health records for this service. Speak with your electronic health record vendors regarding those templates and your throughput through the electronic health record. Work on establishing clinical vignettes to establish those templates. Consider the services of the non-clinical staff involvement and the documentation requirements. And also consider, relative to the other services of your practice, the business cost of rendering this service, documentation requirements, and compliance. Let me pause there for a moment and see if you have any questions, and we'll take some questions in, and if we can answer them real time, we will. Otherwise, we will post those answers for you. And we will also, of course, accept questions by email to my email, which I provide at the end, and by phone, of course. Then we'll go on to a couple of more discrete revenue opportunities. The next one I want to discuss is durable medical equipment. There's a face-to-face requirement for face-to-face encounters and written orders prior to delivery. Again, this came out of the Act of a couple of years ago. Unlike other aspects of the rule for next year, this requirement is effective July 1 of 2013, and it applies to new items of DME. They will require a face-to-face encounter, and these will be specified items. We'll post a link to those items on the site. These will require a face-to-face encounter within 6 months prior the written order. And again, this was added through the Act of a couple of years ago. The face-to-face encounter requirements is in addition to the Certificate of Medical Necessity. The face-to-face encounter can be completed at the same time. There is a payment and a G-code that is involved here. To a physician who documents the face-to-face, if the physician, he or she themselves, do not perform the encounter. If you perform the face-to-face encounter, then of course this service is included in that E&M service. The G-code that would be involved for this documentation is G0454, and it appears that this is going to pay roughly somewhere over between $10 and $15. Payment would go to the non-physician providers, nurse practitioners, and physician assistants who conduct the face-to-face, and that would be through the current evaluation and management codes as now. So again, this is sort of a new element of payment for that documentation of the face-to-face. A co-payment will exist both for the G-code to the physician and the evaluation and management services as currently applies. This requirement is an additional condition of payment regardless of whether the items are paid under the fee schedule or under the competitive bidding program for DME. This regulation does not apply to power mobility devices, which have a 45-day requirement, and it does not supersede other regulations specific to PMDs. The next slide more specifically indicates what has to be documented. And again, this will be posted on the site. And this are the requirements, in essence, to generate that payment under this is the documentation required for that G-code documentation and payment. The CMS description of the covered items that will be on the list that would require the face-to-face encounter are listed on this slide. You can see the specifically mentioned items, and then any item of DME that appears on the fee schedule with a price of greater than $1,000, and then other items can be added through the notice and comment rulemaking period. Again, this will be effective July of next year, and we'll include a link to the existing list of durable medical equipment that's going to be involved.